And we are live. All right. Hello, everyone. Welcome to the ICFJ Global Health Crisis Reporting Forum. For those who don't know me, my name is Stella Roque, and I'm thrilled to introduce a star panel for you today for this webinar for the ICFJ Global Health Crisis Reporting Forum to discuss the challenges to equitable vaccine distribution from global to local perspectives. If you're joining us from Zoom today, please submit your questions on the Zoom chat, which you'll find in the menu options below. If you're watching from Facebook live stream, please post your questions in the comments below the video. With COVID-19 vaccines out, we're here to talk about the challenges to equitable vaccine distribution at the global level, and also the complexities of what happens in the global south at a national level, looking at Brazil. On the panel with us today are a stellar lineup to help us understand these issues. We have Dr. Rifat Atun, Professor of Global Health Systems at Harvard University and the Faculty Chair for the Harvard Ministerial Leadership Program. From 2006 to 2013, Dr. Atun was a professor of international health management and head of the health management group at Imperial College London. And from 2008 to 2012, he served as a member of the executive management team of the Global Fund to Fight AIDS, Tuberculosis, and Malaria as Director of Strategy, Performance, and Evaluation Cluster, where he chaired the panel that oversaw investments of around $4 billion each year in more than 100 countries. We also have here Dr. Claire Standley, an assistant research professor at Georgetown University's Center for Global Health, Science, and Security, with a primary faculty appointment in Georgetown's Department of International Health. Her research focuses on the analysis of health systems, strengthening and international capacity building for public health, with an emphasis on prevention and control of infectious diseases in both humans and animals, as well as public health emergency preparedness and response. Previously, Dr. Standley has also served as an American Association for the Advancement of Science, Science and Technology Policy Fellow at the Department of State, where she supported programs for laboratory capacity building, disease surveillance, and cooperative research across the Middle East, Sub-Saharan Africa, and the Lower Mekong. We also have here Marcelo Leite, a former Nieman Fellow at Harvard University and a Knight Wallace Fellow at the University of Michigan. Marcelo is a science and environment columnist with Folha de São Paulo, a leading Brazilian daily newspaper. From 1994 to 1996, he worked as an ombudsman, a reader's advocate for the same newspaper, where he also led the science, opinion, and international sections. Since October 2020, he has been writing for the blog Virada Psicodélica, known translation Psychedelic Turnaround for Folha. His latest book, Psychonauts in Press, comes out May 2021. And last but not least, moderating this panel is our host, Phillip Martin, a former ICFJ and Nieman Fellow and a multi-award winning senior investigative reporter for the GBH News Center for Investigative Reporting in Boston. Welcome all of you. I'm turning this over to Phillip to run this discussion.
Stella, thank you very much. And your Portuguese is very impressive.
Thank you so much.
I think Marcelo will agree. Right. Hey, folks, welcome. I'm glad you could join us. International Center for Journalists, of course, has sponsored several forums looking at the impact of this pandemic, which has raged across the world. And it's the global impact that we're talking about today in the context of this issue of inequality in as well as inequitable distribution of the vaccine. You may have seen, or some of you may have seen, an article that appeared yesterday in the Washington Post, and the headline says it all: the zero-sum vaccine game. How a dose in the U.S. takes a dose away from a poor country. That is essentially what we're talking about today, those doses that are occurring globally, but also what's happening within countries, within the country of Brazil, for example, the vast nation of Brazil. And I think I'd like to first of all say greetings again to our distinguished panel. I think Stella did a good job of summing up everyone's background, and it's quite impressive. We're going to be very informal here. Going to address people by their first names. And I'd like to start by sort of getting an overview. And I think I'd like to turn to Rifat to do that. What exactly are we talking about in terms of vaccine distribution and how it's working or not at the global level? And what is the ACT, Rifat? And importantly, what role does the private sector play in the partnership with these massive institutional global collaborations that are meant to distribute the vaccines?
Yeah, great. Thank you, Philip. And it's a real pleasure and privilege to be part of this wonderful panel with my colleagues, Claire and Marcelo. I think it's instructive to take a step back and think, where were we when the COVID-19 pandemic struck? In relation to equity, we had huge inequalities between countries. So the rich global north or Western Europe and North America, and then there's a middle group of countries and the very poor countries in sub-Saharan Africa and in Asia. But we also had huge inequalities within countries. And what COVID-19 has done is really accentuated these inequalities and further magnified them and made them worse. And we're seeing this even in countries that have universal health coverage. For example, in the United Kingdom, that is well known for its national health system, we're seeing that Black and minority ethnic groups have been the worst affected by COVID-19, and they've suffered the worst death rates. We're seeing a similar situation again in Brazil, again, which has a really celebrated unified health system, SUS, that has done so well to save so many millions of lives over the years. We're seeing, again, a difficulty in responding to the COVID-19 pandemic and huge inequalities in relation to access, but also outcomes in terms of deaths, particularly again in Black and minority groups and in indigenous groups. So here we are, vaccine, a critically important tool to help us fight COVID-19 pandemic. And what we're seeing is that these structural inequalities that exist have been magnified and accentuated once again. We're seeing sort of a three different tiers in terms of vaccine access and distribution. The first, we have North American countries, the US and Canada, and Western European countries that have been able to enter into agreements to purchase these vaccines and stockpile them. I mean, some countries have purchased 10 vaccines per citizen. Then we have a group of countries in the middle that have been able to access some vaccines, but not enough for the whole population. Then we have countries in sub-Saharan Africa where there has been very limited vaccination. So in all this talk about equity and rights, they've all gone out of the window. It really is unacceptable in the 21st century. The response to the COVID-19 pandemic is as strong as the weakest link in the chain. As we've heard, no one is safe until everyone is safe. Of course, there are important initiatives like, as you mentioned, Philip, ACT Accelerator, the Access to COVID-19 Tools Accelerator. And as part of that COVAX, the COVID-19 Global Access sort of initiative that WHO is leading. But in spite of these efforts, we really are not getting the vaccines to individuals who need them. And not just in poor countries, even in rich countries, we are seeing that, particularly in the US and a few others, we are seeing that the most vulnerable groups in terms of income level are not able to access these vaccines. So we're seeing this inversion of the need and what is being supplied. Those who need the most are really not getting access to the vaccines that could be game changers for them in terms of saving their lives. So that needs to change completely. But I'm sure Claire could add much more on COVAX.
And it would seem to be axiomatic that no one is safe until everyone is safe. But that, however, doesn't seem to be playing out on the global scale, Rifat. And as Claire, as Rifat pointed out, you also have a situation where you have COVAX leading the charge. But at the same time, it is caught up in this contradiction of where you have even Canada, which is planning on distributing over 300 million doses with a population of 38 million, is also subscribing to COVAX. How do we clear up this contradiction? How do we basically establish more equitable distribution, given the fact that these countries have already plowed ahead?
Yeah, that's a great question. And I think it's very important to note, first of all, so COVAX, as Rifat mentioned, is one of the 3 pillars of the ACT Accelerator. It's the one that focuses on vaccines. And I think it's important to note that the COVAX, the approach to COVAX was intended to give all countries access, regardless of their ability to pay. So the idea was to create a level cooperative playing field where COVAX facility could help navigate the landscape of vaccine production and manufacturing on behalf of participating countries, and provide some collective purchasing and bargaining power. But it is important to note that participating countries can either self-finance, and so there's a route into the COVAX facility for those higher income countries that are willing to pay for the vaccine directly, as well as critically the opportunity to support access for those countries that don't have the ability to pay. And there's a separate component to COVAX called the Gavi Advanced Market Commitment, or COVAX AMC, which is the element that's providing the funding assistance largely through development assistance, but also some philanthropy in the private sector to ensure that those lower and middle income countries can have access. And so from the beginning, there was a mechanism for countries like Canada, which was a participating country, to access vaccination through COVAX. And that was a very important part of it, that there was going to be an insurance policy, even for countries that were exploring their own bilateral deals, to be able to use this mechanism as well. That being said, COVAX is working hard, I think, to try and address some of the inequity concerns. And so in the initial distribution forecast for their first tranche of vaccines, and this forecast came out just about a week ago, there were actually 4 criteria that were used to determine which countries should receive doses in this initial distribution. And one of the criteria was that if a participant country had already started vaccination, it would not be included in that initial rollout. So again, trying to recognize that some countries have pursued these bilateral deals, have received vaccinations already, and have started their rollout, they would not necessarily be eligible for getting vaccination through COVAX at this stage. That said, there are countries, and again, I think Canada is a good example, where they have pursued many bilateral agreements, but they haven't managed to secure some of those doses, so they haven't started their rollout. And so they are on that list of the initial distribution forecast for COVAX, despite having ordered so many doses. And I think that is a key aspect of this inequity, that there is a distinction between the bilateral agreements to secure large numbers of doses versus the ability of those countries to actually receive those doses. And so countries are buying up many more doses than they need because of that supply and demand contradiction that we're seeing. So COVAX is trying to address it. It's going some way to it, but the number of doses is just not sufficient at the moment to ensure that all of the participating countries, and particularly those who don't have the ability to buy the vaccine themselves, will receive the number of doses that they need, even just to address their highest priority populations, which is the key that COVAX is trying to target.
Well, Claire, as a lead into Marcelo, of course, there could be fewer countries with higher priority than Brazil, which has had a high incidence of COVID-19 infections. But you also have a situation where you have a president who is, as Marcelo will talk about, is a denialist. Is Brazil among those that are part of this this schematic, if you will? And Marcelo wondering, Marcelo, yeah, there you go.
Okay, hello everybody. It's a pleasure to take part in this distinguished panel with Claire and Rifat, the real experts here. And special thanks to Stella for organizing this webinar. And well, Brazil is sort of in the middle of those 2 extremes that Rifat has mentioned. We are a middle income country with a robust health sector and very good vaccine programs since the 1970s. And but in spite of all these favorable conditions, we are doing not so well when it comes to confronting the COVID epidemics here in Brazil. We have now, again, in our second run of COVID, we have about 1,000 deaths per day, which is very high for Brazil. And altogether, 235,000 deaths accumulated so far, which makes us the second place in the world, or maybe third. And which is important when it comes to inequity. That's the central theme of our conversation here. Blacks are mostly affected by deaths in Brazil. About 60% more deaths among black people and poor people in Brazil than among white people. So I would say this is the price we pay for having elected a denialist and president back in 2018. But I won't go too deep into that, because the central part of our discussion is not politics or ideology. I just want to give you an idea of what we inside Brazil are perceiving as a vaccine fiasco. We have, after 3 weeks of vaccination, we have vaccinated only 2% of the population. And we are vaccinating about 170,000 people per day, which is much less than, for instance, in 2019 with the flu vaccination campaign, when we had almost 1 billion people each day vaccinated. So this is, of course, a result also of the scarcity of doses that we have right now. But not only that, there are logistical problems, lack of coordination from the federal government, and many different systems applied in each state. So it's kind of complicated. We have closed agreements for the procurement of vaccines for about 246 million doses, which is enough for only about 50 or 60% of the population when you consider 2 doses. And best case scenario would be 64%. And we have an uncertain supply of ingredients coming from China, also because of diplomatic and political problems between the Brazilian and the Chinese government. And when it comes to equity, it's important to know that Brazil has established a priority list. So in the first group of people who are getting vaccines in Brazil, there are 4 categories: health workers and persons above a certain age, with 80 years of age and then going down subsequently. Indigenous peoples living in villages or reserves, so to say, indigenous reserves, and also persons with comorbidities such as diabetes, cardiovascular disease, and so on. One can say there's a difference between those 4 categories when it comes to equity, because of course, health workers, doctors, nurses tend to be richer people in the population, but I think it's justified because they are on the front line, so they are running a higher risk of getting, and they are needed to attend to the other people. And when it comes to age,
one question, however, Marcelo, just one question, and I think this is true across the globe. Even though people are listed as being on a priority list, are they in fact being prioritized? Albeit the health workers, I don't think anyone would argue about that as a priority. Are you actually seeing indigenous people, Amerindians, for example, actually being prioritized, or poorest of the poor, Black people in the favelas, for example, actually being prioritized? Or is that more rhetorical than true?
I would say when it comes to Black and poor people, it's more rhetoric. There's no real priority. Also because age tends to favor the richer because of differences in life expectancy. Just to give you an idea, the average life expectancy in São Paulo is about 70 years of age, but in the best neighborhood could get to 80, and in the poorest neighborhoods could get down to 57 years of age. So this gives you an idea how much the age criterion favors the richer people, at least people who are best off in society. Indigenous people, the population who live in reserves are not that big. It's about 700,000 people, and I think that's going on quite well. But you have to consider the problem is that the pace is very slow. So everybody is getting, it is going too slow for everybody, for all these categories. And yeah, I think that's it for starters.
I'm going to ask, yeah, let me ask Rifat and Claire, please opine, give us your qualified views of, if you will, indigenous people around the world. They seem to always be, not just in Brazil, but wherever you go, they seem to actually, regardless of what is written on paper, seem to be the last priority. Are we actually seeing that? Rifat?
Yes, I think Marcelo provided a really great picture of the situation in Brazil, and that age, although a useful metric to use for categorization, is not sufficient, because it really doesn't take into account other risk factors, socioeconomic risk factors, but also ethnic background, but factors such as obesity and having chronic disease. And one's risk of dying from COVID-19 can increase very substantially with the addition of those risk factors. And the stratification systems, the systems we're using to group people, are not really sophisticated enough to target these groups. And even in the context of US, some states that have tried to do that gave up fairly quickly, and they said, we really don't have the systems to manage this level of complexity, which is quite surprising in the 21st century with digital data systems. And it's a year since COVID-19 problems began, so we're really not well prepared. Now with indigenous groups, but also I think we should focus on the minority ethnic groups, not just the indigenous populations, where we have congregate settings where these individuals are in a well-defined geographic area. Yes, one can actually introduce targeted interventions, but when these groups are dispersed in different geographies among the general population, the response has been less satisfactory, because we don't have the systems to target high-risk individuals. And age in itself is an important but not sufficient way of categorizing risk individuals. So again, this inversion is happening. Those who really need it are not getting the vaccines.
What is the difference in that context between equity and equality, briefly?
Well, equality is, people with, everyone gets the same, but each individuals are not the same. So if individuals are the same, that's fine, but individuals are very differently situated in terms of their income, their education, their risk factors, their living conditions. So equality is not enough. We need equitable access, which favors those who have the greatest need. That is what I would call fair, that is justice, but we're not reaching there. Equality is regressive. It doesn't actually favor those who really need the services.
Thank you, Rifat. Claire, one of the things that Marcelo, of course, mentioned, he's talking about the geopolitical aspect of this, the Chinese attempting to distribute the vaccine in Brazil. Of course, that is a lot of this is what China and Russia are doing, and the United States and Great Britain and others, or Germany, what are they're doing. This is another form of public diplomacy. It's another form of influencing the world, but it also has a practical impact. Can you talk about the distribution, this race for to distribute the vaccine, and how the geopolitics of it is also impacting people's real lives on the ground, or not?
Yeah, it's a great point. And just before I answer that question, I just want to underscore what Rifat was saying about the inequities. And you know, I think that these intersectional analyses of how social determinants of health are most greatly affecting the poor and those who need the vaccine the most is something that really needs to be emphasized more. And to that, I'd add also refugee populations, I think, are at large risk of being overlooked by some of these vaccine distribution strategies. And countries like Jordan, which are offering vaccines freely to refugees, are really leading the way in that front. But there are still challenges, of course, to accessing some of those populations too. But in answer to your question, Philip, you know, I think there's a number of things. One important point is that, of course, all of the vaccine candidates are different. The data are just coming out. We're just seeing the results being published. One important thing to note also is that, for example, each country is approving, or each country bloc in the case of the European Union, for example, is approving different vaccines at different rates. And so that's having a big impact on which vaccines can be distributed where. The WHO, for example, has only issued one emergency use listing for the Pfizer-BioNTech vaccine. They anticipate the AstraZeneca-Oxford one will come shortly, but that's obviously severely limiting the availability of doses through COVAX, for example, because they cannot distribute or plan to distribute vaccines that haven't been listed for this emergency use listing. So that in itself is part of the problem. And I think we are seeing a certain amount of prejudice related to how data are being interpreted across the various vaccine trials from different countries. And we are starting to see some geopolitical alignments occurring in terms of the countries that are accepting certain vaccines or authorizing the use of certain vaccines, and where some of the production, the manufacturing companies are choosing to advertise or to set up bilateral deals. So for example, you know, there are a number of countries in sub-Saharan Africa that have accepted one or the two Chinese vaccine candidates, and I think again strengthening some of the perceptions of Sino-African alliances there regarding global health diplomacy. India is another one that's really put a candidate forward and is selling to Afghanistan, for example, again as part of the geopolitics of the South Asian region. So I think we're definitely seeing this play out. And I think that we do also need to make sure that the research and the trials that come into this are really solid so that we can have the largest view possible of where the risk factors are and the populations that will benefit most from the various candidates. And again, I think one of the advantages of something like COVAX is that it's trying to manage that global picture. It's trying to look across all the trials and provide a comprehensive view to all the participating countries and to help facilitate that process, which I think is another benefit of the program, which is maybe sometimes overlooked.
I had understood from a Lancet article that Russia's vaccine is 91% effective, but Russia's reputation probably in terms of geopolitics right now is pretty much in the toilet, if you will, and so that might be preventing some people from actually accepting, if you will, a vaccine, even if it is effective. But I guess the same could be said of China and the United States, depending on one's point of view. Do you find that to be a barrier?
Speak to that very quickly. Yes, I think that is something of a barrier. I mean, there were concerns early on about the extent of the trials that had been done on the Russian vaccine, for example. So there were concerns that the trials had been rushed or perhaps even bypassed. You know, great that the efficacy data now is looking very positive, but we do want to make sure that these vaccines are safe and have been ethically produced. Particularly given the amount of hesitancy that we're seeing around the world on the uptake of these vaccines and the unprecedented speed at which they've been developed. We know that the scientific rationale for these vaccines is very strong. It has been well established. So in that sense, they're not novel, but they are new candidates out there that we need to be very, very sure about before we distribute globally. So I think that it's worth being cautious about the data coming out, but at the same time, we shouldn't let our prejudices cloud our rational judgment when it comes to the data.
Rifat, Claire, Marcelo, feel free to, of course, address these questions amongst yourself. I'm the moderator, of course, but you might have questions yourselves. But let me also mention that we're going to take questions from our audience in just a little while. One thing you brought up, Claire, and I'd like to address this to Marcelo. I'm really curious about this. Refugee populations, and when you think about Syria, when you think about the numbers that are still coming into Europe from Africa and North Africa, and when you think about the numbers coming from Venezuela, for example, into Brazil, still people are still pouring into Brazil, or the numbers are coming from across the Mexican border, or attempting to, into the United States. How do you address that? People's desperation versus the very real fear of the pandemic. Marcelo, has this been a question that's come up, for example, in Brazil, and certainly in the context of where folks are coming in into the country from Venezuela?
Well, I wouldn't say so, Philip. As far as I know, the COVID epidemic doesn't have increased the number of Venezuelans that are coming to Brazil. The flow is not so high as it used to be 1 or 2 years ago. And of course, Brazil having a universal access system, even Venezuelans that come to the state of Roraima are entitled to be treated and vaccinated. At least I assume they are, and they will be treated if they come. But I would like to go back to the geopolitical situation. And it's funny because in Brazil, the relationship with China has played sort of a positive and also negative role, because we have two agreements with vaccines in Brazil, one with AstraZeneca from the federal government and the Fiocruz Institute in Rio de Janeiro, who is going to manufacture the vaccine next semester. And also CoronaVac from Sinovac in China. There's an agreement between the government and the state of São Paulo with Sinovac to manufacture the vaccines here. What happened is that the governor of São Paulo, being a political rival from Bolsonaro, from President Bolsonaro has attacked very strongly the Chinese vaccine, as he used to refer to the CoronaVac vaccine. And this played a role in also spreading doubts in the population about vaccination and the safety of vaccination. It was really a bad influence, this mixture of internal politics. And besides that, President Bolsonaro is also a very staunch anti-communist, and he attacked China with very disparaging comments on this issue and on other issues for a long time. And so I think that the delay in the delivery of ingredients from China, even to the state of São Paulo, has a lot to do also with that diplomatic, difficult situation between China and Brazil now. So this is a clear example, in my opinion, of how domestic politics and also geopolitical and diplomatic ties between two countries can play a role and make things more difficult for vaccination, for instance, what happened in Brazil right now.
Yeah, and may I follow on that, Philip, because I think this is quite interesting. Unfortunately, geopolitics is getting in the way, but we're also seeing some interesting relationships developing. And we're also seeing a resetting of the global health architecture in a way. Even in the context of European Union, we're seeing Hungary actually purchasing vaccines or reaching an agreement to purchase vaccines from China, from Sinopharm. And we're seeing Oxford University working with Russian scientists to test combination of the Oxford and AstraZeneca vaccine with Sputnik 5 vaccine. So I think some countries are being playing the geopolitics quite strongly, and some are actually being much more pragmatic. We're also seeing very interesting alliances developing. But I mean, the case of Brazil is interesting in the sense that Brazil has very strong capability in vaccine production. Institute Butantan is a really outstanding research and production entity, and they could very easily, and they've actually started producing vaccines. You know, with the strong leadership, the capacity could have been augmented far earlier. So when the vaccine was, the candidate was ready and approved and the trials were completed, the vaccine production could have been scaled up very rapidly. We've missed these opportunities because of very poor leadership in many countries, unfortunately, with the consequence of with consequent deaths of so many people. But coming back to Africa, which is really missing out, and Africa has a population of 1.3 billion people. I mean, COVAX has, you know, there's much to be commended in terms of what they're doing. But if we look at the projections and the numbers, we'll have sort of 90 million or so doses being sort of distributed starting in February. And then by the end of 2021, about 600 million doses. But we're not going to vaccinate the African population by 2024 at this current rate. This is unacceptable. You know, there's a whole continent completely missing out on the vaccination. This is really delayed, slow uptake. We should have thought about establishing manufacturing facilities in the African continent to rapidly scale up vaccine manufacturing and make it available rather than just waiting for 3-4 years.
And this is also exacerbated, of course, by the variants. And so someone had, in fact, had, let's see, Maria Laura Franciosi. She's a journalist from Italy living in Brussels. She addresses this in the chat. And I guess one of the questions would be for Claire is, with the fact that they have not prepared, as Rifat has pointed out, for let's say the manufacturers have not prepared adequately for Africa, of a vast continent. What can be done in retrospect? What can be done now in terms of that distribution? A place like Rwanda, I understand, with only about 1,000 people have so far received the vaccine.
Yeah, and I think this is again where we're going to see some of that vaccine diplomacy at play. You know, if you have large manufacturing capabilities in countries like India and China, and they're willing to provide some of their partner countries in Africa with large numbers of doses, particularly since China has obviously had already a very ambitious vaccine rollout domestically, and India is in the midst of doing so as well. If they can successfully demonstrate large-scale rollout in those contexts, then I think there's a strong likelihood that that could be mirrored in Africa as well. And you know, I certainly hope so. I hope that there's a push to do so, since, as Rifat mentions, it's completely unacceptable, the current situation. And again, you know, I think that we can rethink. I hope that there's going to be greater opportunities and greater investment in something like COVAX, although again, the pace is just currently insufficient, and we are reaching a point where rich countries are going to vaccinate large proportions of their population before any significant number of Africans are vaccinated, leading to even greater inequities in terms of global health and economies because of the way that trade is being impacted by the pandemic. And so again, I think this is a really urgent need, and the more that we can collectively come together to address some of these issues, the better. But I don't see it really happening now. And that is exactly why India and China have this opportunity to step up and become real leaders in global health through providing services where other countries are not.
One question, of course, in that, again, in that context, when you talk about equity, you folks, you probably may have seen this story or read about it where a couple in British Columbia, in Vancouver, basically flew up in a private plane to Yukon Territory among that's in an area run by First Nation, and basically pretended to be hotel workers in order to be vaccinated. It's it's just an illustration of efforts by folks to cut the line, if you will, those who are wealthy. But it's also, of course, an extraordinary metaphor for what is happening on the world scene. But it also begs the question of Canada in terms of the way it's also distributing the vaccine. I can't get over the fact that you have over 300 million doses being ordered for a population of 38 million, while so many around the world, from sub-Saharan Africa, all of Africa actually, to Syrian refugee camps are suffering. What can be done, if you will? And this is a question to Claire and Rifat. What can be to those countries who are practicing vaccine nationalism? That's a great question. Rich countries stockpiling vaccines at the expense of poor countries. What will be the consequences of national self-interest in their POV?
Well, this will further sort of deepen the inequities that exist, as I've said earlier. We have a whole continent, African continent, that is not receiving and that is not going to receive enough vaccines until 2024. That is completely unacceptable. And again, the response to COVID-19 has to be a global response. We have a pandemic. We don't have isolated epidemics in one or two countries. So there needs to be global solidarity in addressing the COVID-19 pandemic. I think, 1 year into the pandemic, countries should have learned that. And what's important is that the countries that have reached agreements to purchase large numbers of vaccines, once they've vaccinated their populations, they should make these vaccines available and donate them, rich countries, free of charge to sub-Saharan Africa. I think this will be a very important move. In fact, not doing it would be unacceptable.
And just to add to that, I know that, for example, in the EU, those commitments have been made, but I would argue that that's almost not good enough. Again, you're effectively putting your partners on the other side of the world into a second-class citizen category by saying, well, we're going to look after ourselves first, and then we'll donate the vaccine to you. And so, what do we expect people in African countries to do in the meantime? It's just completely unfair. And so I do think that we have to rethink the way this is happening. And I think one of the big tragedies of this is we knew that this was a possibility. We knew that this could happen. And of course, COVAX, again, was set up to try and bolster against some of this. But back in 2009, with the H1N1 pandemic, influenza pandemic, we saw exactly the same thing. Rich countries stockpiled Tamiflu. They did advanced purchases of all the Tamiflu supplies. Many poor countries were unable to get any doses or insufficient numbers of doses. And thankfully, that pandemic didn't turn out to be quite as virulent as we had feared. And so the consequences were not so grave. But that absolutely could have turned out differently. And so again, we saw it just over 10 years ago, exactly this type of thing play out, and we could have been better prepared for it. And yet somehow, despite the best efforts of the WHO and others, and many other well-meaning entities, we somehow have seen vaccine nationalism still come to the fore and dominate the discourse at this point in time. And I really hope that this isn't a symbol for where global health is going. And I hope that we can overcome this and really come together for a much more equitable view of global health moving forward.
Let's open this up to our audience. And Marcelo, you have I
have a question.
A question, please.
It's for the three of you, Rifat, Claire, and Philip. Do you think that the fact that now the president of the US is Joe Biden and there's a sort of renewal of multilateralism will make any difference in the global scale, having the biggest country or the richest country sort of going back to multilateralism?
Interestingly, go on, Rifat, please.
Well, no, I sincerely hope so, of course. And we're already seeing a shift in the US context. The response is becoming much more coordinated and more robust and rigorous with with very capable individuals, some from my institution, at the helm driving this. And certainly President Biden and his administration has signaled very strongly their willingness to reset the global relationships, which has been strained, to use a conservative word, among friendly nations and among all the nations. So certainly they should help. And America, with the capabilities and the financing it has, can contribute much to accelerate the response in countries where there's a huge need.
The very question that you asked, it was swirling in my head, Marcelo, after you had talked about Bolsonaro's denialist policies. He is known as the Trump of the South, quite an interesting name. And his approach was Trumpian in terms of his approach to China and others. And I think with the U.S. re-engaging with the WHO, for example, I think, and other international organizations, I think we will see more cooperation and a more, if you will, unified multilateral approach to vaccine distribution, as Rifat said. Claire, any thoughts on that point raised by Marcelo?
No, I completely agree. I mean, I think that there is obviously a clear commitment to multilateralism within the Biden administration. They've joined COVAX, they're rejoining the WHO. These are all powerful symbols. But again, unfortunately, the US has to cope with a response that to date has been really lacking. And so there's a lot of energy being invested rightly in the domestic response and getting that under control. And I fear that has weakened the US's position in terms of being an international leader in this response effort. I think that will change as things progress, but it has set the US back in terms of taking that position.
Okay, folks, thank you, Claire. Folks, if you have questions, we'd like to hear from you. There's one here from David Hathaway. Brazil used to have a private generic and Me Too pharmaceutical industry that could license or even get compulsory licenses to meet the nation's needs at affordable prices. India still does. What happened? Anyone want to take that on? Marcelo, anyone?
Yeah. Well, I would say that Brazil sort of backpedaled in these issues because of a change in the political panorama in the country. One could say that the politics in Brazil became more conservative in the last 5 or 6 years after the Workers' Party government. But David Hathaway, whom I know, is right. We sort of backpedaled in this issue, and there has been not so much investment in the pharmaceutical industry in Brazil. There are no government federal policies directed to that, as was the case in the past. And in general, not so much investment in science and technology. So that's what happened, I think.
And if I can just add very quickly to that, I think because this is all about equity, there's obviously been a big push also for publication of the licensing for the COVID-19 vaccines, right? And so there's been conversations ongoing about how particularly those vaccine candidates where public money was used, should those licenses actually belong to the public and the private sector not be allowed to profit from them in the way that they are. This is a global good. It's critically important to restoring the global economy. And so I think there was a question in the chat actually related to that about, some of the pharmaceutical companies raising their prices and only and preferentially giving treatment to those countries that are willing to pay above asking price or the highest prices. And I think these issues are all linked together. Is this an opportunity to rethink how the public good is recognized when it comes to things like mass vaccination or countermeasures for pandemic threats? And to what extent do we allow private industry to profit from this kind of crisis versus acknowledging the absolute need to allow even those people in those countries that can't afford to purchase them directly to have access to these vaccines? So there's some very big questions here that go far beyond even just global health, but are deeply embedded in the concept of equity and I think need to be considered before we face the next pandemic, which, as we all know, there will always be another health threat coming down on the horizon. So we need to be prepared better next time.
Rifat?
No, absolutely. I think Claire has summarized it very, very nicely, and it's very important that capabilities are developed for doing the trials, but also for manufacturing, and we should think how creatively we can use sort of public-private sector partnerships, because private sector can bring agility and expertise. For example, in supply chain management, in developing manufacturing facilities, so how we can harness all the capabilities, because this is affecting everyone, and ensure that this is an opportunity for the private sector to show their capabilities, but also contribute to broader and greater social good. And also, I think the international development agencies and banks, World Bank and the regional development banks, could also play an important role in funding the necessary infrastructure in Latin America, as well as in the African continent, to develop these capabilities. So let's not miss these opportunities, and not wait for the next pandemic. We should be acting now, because we're not going to get vaccinated in many countries until 2024.
Wow, I am breathless when you hear that. When we talk about just think about the possibility of how long this pandemic could go on. There are two questions here, and I'm thinking about our time. We have about 6 minutes left, and I'm going to ask these and see if you can address these within that time limit. How do we? This is from Chadera Rose Camille. How do we ensure vaccine equity? Africa seems to be left behind. The Oxford AstraZeneca vaccine sent to South Africa had expiration date as April, which isn't enough time to distribute. And I'll ask the second question too. So we have both of these queued up. On donating extra doses, this is from Suan Lim. On donating extra doses of vaccines, is this a viable solution to the current inequities in access to vaccine? What are the possible repercussions on the existing health inequities between countries? Please, however you'd like to take those two questions on, panel.
I can briefly, these are really excellent questions. So I think there's some short-term actions that can be taken in order to address the inequities that exist and the huge delays that many poor countries, including the African continent, is and will be experiencing. So it is important that there's no stockpiling and these vaccines are made available. But that doesn't solve the problem for the next pandemic or the future. So we also need to invest in capabilities and infrastructure to ensure that there are manufacturing facilities to be able to scale up rapidly enough in the African continent, and also in countries of Latin America and Asia, with appropriate supply chains to ensure that the vaccines that are produced are actually available and reach the individuals who need them, because vaccine is not equal to vaccination. And we have many weak health systems that need to be strengthened.
Good point. Not equal to vaccination. That's right. Even in terms of delivery systems, that's a huge problem. Claire?
Yes.
I was just going to say exactly that point, which is that I think we're learning a huge amount about what kinds of vaccination strategies work in different contexts. We're establishing these incredible new platforms for manufacturing. And as Rifat says, I think this is an opportunity then to create these longer term systems, provided we put the governance approaches in place to make sure that we do better next time, that we plan appropriately. But I actually would love to hear from Marcelo about the second part of that last question in terms of possible repercussions. What do you think is going to be the impact to Brazil, for example, on the problems that you've seen so far with vaccines?
Well, difficult question. I would say in general that the image of science and technology is getting better in Brazil, the need to invest in that, although not from the federal government, which is now in place in Brazil. You don't see much of this movement in the right direction, but I would say in the general population and then the public opinion, is clear now that we do need investment in those kind of facilities. For instance, as Rifat has mentioned, Fiocruz and Instituto Butantan in São Paulo, Fiocruz in Rio de Janeiro, Instituto Butantan in São Paulo, do have capacity to manufacture vaccines. And there has been some investment, also private investment in Instituto Butantan, which is a good sign that society is really taking note of that. And but it's too little, too late, I would say, when it comes to the pandemic. We still don't have the capability of manufacturing all the vaccines we need, and we depend on China and India to provide the ingredients, because the active pharmaceutical ingredient is not yet produced in Brazil, manufactured in Brazil. We do need those batches coming from China, especially from China. Both AstraZeneca and CoronaVac, the ingredients are coming from China. And then there's all this diplomatic problems between China, which some people think are behind the delay in delivery of those ingredients to Brazil. But in general, I would say that maybe the future government of Brazil, the next one, would put more investment and priority in science, technology, and this kind of investments. I hope so.
I think we all do. I think we also have to hope that the imperatives of capital and selfish nationalism also don't override the need for a global response to this issue. I'd like, if you will, the three of you to sum up very quickly within the next 2 minutes, 3 minutes, 2 minutes, I think we have, starting with Rifat and Claire and then Marcelo. What has to happen next in order for this equity to actually take hold, for there to actually be equity?
Yes, important question. First of all, we need to take the issue of inequalities very seriously. This shouldn't be just talk. We need action. We need to put systems in place that recognize not just recognize the magnitude of the inequalities that exist, but the nature of inequalities and the underlying reasons, and then put systems in place to address them. Because unless we address these sort of so-called upstream sort of determinants that lead to inequalities, again, we'll come to the next health threat with these inequalities in place. Secondly, we need to have systems in place, and when we need to be prepared, and we need to be able to respond to recognize which vulnerable groups need to be appropriately supported in the epidemic. It's not just about vaccine. I mean, if you think about employment, unemployment, the poorest segments, or those with lowest income and in informal jobs, have had really terrible outcomes in terms of losing their jobs, not being able to hold on to their employment, and also adverse effects on their health. So we need to take stock, and rather than talking, put systems in place to prepare, and importantly to act when it matters.
Claire?
Yeah, I would just add to some of what we said before and make 2 points. So one is, I think we need to continue to strengthen multilateral institutions that relate to global health governance. There's been a lot of talk about reform and bolstering the WHO, and that needs to absolutely happen in a very clear-sighted way. And then I really liked both Rifat and Marcelo mentioning the idea of strengthening domestic science and technology and manufacturing capabilities. I think we need to rethink global supply chains and create those opportunities for greater strengthening within across the world, and not just in high and middle income countries. So that's something I think that could be really positive, both in terms of the broader economic gains, but also in terms of strengthening health security more generally.
Marcelo?
I think that the takeaway message for me is something that Rifat said in the beginning, that no one is safe until everybody's safe. And in order to go in the right direction, I would say that for starters, we should put pressure on the governments, rich countries, governments that are stockpiling vaccines, that they should donate the surplus doses they have to poor countries, or maybe through COVAX initiative. And the second point is what Claire just said. We have to strengthen the production capabilities in middle-income countries, to say the least, in order to provide, to be able to become more independent from rich countries and industrialized countries. I think that's the way to go.
Look, thank you, all of you. I am truly honored. I really mean that from the bottom of my heart to have taken part in this panel discussion with you, this International Center for Journalism panel. And I'm going to, at this point, turn this over to Stella to lead us out. Stella?
Thank you to everyone for this excellent discussion. I have to say it was a really in-depth webinar on this topic, and it was absolutely necessary for us to have this conversation. And I hope all our forum members really did benefit from it. If you're not a member of the ICFJ Global Health Crisis Reporting Forum yet, and you're attending this event via Zoom, I encourage you to please find the group on Facebook, or for more information on the forum, please go to www.icfj.org. Please don't forget to fill out the survey coming to your inbox after this webinar. ICFJ would love your feedback to improve our programming for this series. And importantly, we will have a recording of this webinar available on the ICFJ and IJNet YouTube channels. So you will have this as a continuing resource to go back to and refer to. Thank you again to all our panelists. Thank you so much for sharing your expertise. And thank you to Philip for moderating again, and Claire for having you back. Marcelo, Rifat, thank you very much. I hope you all have a wonderful week.
Thank you, Stella.
Thank you, Stella.
Thank you so much.
Much appreciated.
Thank
Bye.
you, and
Thank
see you next
Stella.
time.
Bye.
Bye.
Thank you. Bye.